I want to introduce you to one of my patients. Her name is Amy. She's a 42-year-old G2P2 who underwent a total laparoscopic hysterectomy, bilateral salpingo oophorectomy, bilateral mastectomy with reconstruction, secondary to having a BRCA2 mutation. Since her surgeries, Amy has experienced a tremendous amount of vasomotor symptoms. She reported hourly hot flashes. She's not sleeping well because her sleep is frequently disrupted from night sweats. Her symptoms began to affect her personal and professional life. She works as a professor. She's experiencing more anxiety, irritability, and now having discomfort with sex. Her vagina is dry despite the use of lubricants, and this is really impacting her relationship with her partner. She consulted her oncologist, who then referred her on to the menopause clinic for further counseling. I want you to think about what you might do for a patient like Amy. Women who undergo a surgical menopause prematurely before the age of 50 have unique health risks and treatment needs. Their care needs to be individualized based upon their health risk as well as their personal life goals and their values. So today we'll describe the risk and the benefits of oophorectomy, talk about the latest treatment options, again, to mitigate those risks, and lastly, talk a little bit about how we can individualize the care for these women using a shared decision-making approach. There are about 600,000 hysterectomies performed for benign reasons every year, and about 40% of those are accompanied by an oophorectomy, bilateral oophorectomy for benign reasons. So this yields about 240,000 oophorectomies performed annually. In addition, there are oophorectomies performed for other pathologies, benign pathologies, and standalone procedures meant to reduce the risk of genetic predisposition to ovarian cancer and breast cancer. There are many factors associated with premenopausal oophorectomy. Age has repeatedly been found to be an independent risk factor for elective oophorectomy and appears to play the most dominant role in the decision to either remove or retain ovaries. Following the release of the Women's Health Initiative study in 2002, there was an acute decline in oophorectomy among all age groups, most notably, though, in the 45 to 49-year-old age group. The risk for women who were older than the age of 50, though, increased. The rate of oophorectomy today in these age groups is 60 for women who are 45 to 49 years old, and even higher in women who are greater than the age of 55. A personal history of breast cancer is associated with oophorectomy, as well as being a BRCA gene mutation carrier. 60% of these carriers undergo prophylactic oophorectomy between the ages of 35 and 40. A family history of breast cancer or ovarian cancer, even if there isn't a genetic mutation association, has also been found to be a predictor for who will undergo premenopausal oophorectomy. And lastly, examining the Michigan surgical quality data, Finner and colleagues found that the route of hysterectomy as well as the indication for hysterectomy matters. Women who undergo a total vaginal hysterectomy or laparoscopic assisted vaginal hysterectomy are less likely to have their ovaries removed, as well as those women who undergo hysterectomy for prolapse. When I think about the ovary, I think about Shakespeare's play, The Midsummer Night's Dream, and there's this quote, "Though she is little, she is yet fierce." So these small little endocrine organs are really powerhouses. They produce estradiol, testosterone, and progesterone, and their effects in the body are far-ranging. Over the course of the transition to menopause, there is a natural decline in estradiol production as well as testosterone production. When we remove the ovaries, there is this acute, abrupt decline. And so the premenopausal hormonal profile is much like the postmenopausal hormonal profile, despite how those ovaries stop functioning, whether surgical or natural. though when you remove these hormones, you get an acute onset of symptoms that are often more severe and longer lasting after a surgical menopause. So following oophorectomy, women have more severe symptoms, and when we look at the figures here, we see those women in green are the ones who've had an oophorectomy, and at all time points they have increased symptomatology, whether or not that's psychological, vasomotor, somatic, and sexual function. And again, many of these women will have a longer duration of symptoms. Estrogen deficiency related symptoms and diseases can have a major effect on women's quality of life, and again, can have significant impact on multiple organ systems, the cardiovascular system, the skeletal system, the neurologic system. As well, it can affect cognition and sexual function. It appears that estrogen therapy specifically can mitigate these risks and bring more balance to this risk-benefit equation. And certainly there are many benefits. So we can completely, almost completely eradicate ovarian cancer if we do premenopausal oophorectomies. We can decrease the risk of breast cancer, as well as the need to do surgery in the future for, on the ovaries for ovarian pathology. So I would like to consider each of these symptoms, each of these risks today. 75% of menopausal women will experience troublesome vasomotor symptoms, those hot flashes and night sweats, and probably having one right now. These symptoms are associated with irritability, diminished sleep quality, as well as difficulty concentrating, and an overall poor life status and poor quality of life. These symptoms will persist for, on average, 7.5 years, and in some populations, they can last even longer. In the study of women across the nation, the earlier the onset of menopause was associated with a longer duration of vasomotor symptoms. The economic burden of untreated vasomotor symptoms is huge. In a study of 250,000 working women, there was an increased loss of work, 1 million extra medical visits, as well as 400,000 million more dollars in insurance bills, with leaving these symptoms untreated in premenopausal oophorectomized women. So let's talk about the vagina. We already determined that we own it, right, from our M&M earlier. Yeah. So we really do need to own these symptoms. 45% of women who are menopausal will experience what we now call the Genitourinary Syndrome of menopause. Estrogen is the main physiologic regulator of the vagina. It is responsible for blood flow to the vagina, lubrication, and through its stimulation of lactobacilli, it maintains an acidic pH. The loss of estrogen can cause many of the changes that you've seen when you've done exams. It's the atrophied vulva and vaginal tissue. It's the constriction of the vaginal introitus, and when we put a speculum in place, we may see a completely obliterated cervix due to those atrophic changes. The really shocking thing I find is that how many women, given that this condition affects so many women, the lack of treatment for these patients. Only 7% of women will receive treatment for these symptoms, and the treatment rate is even lower in women who are breast and GYN cancer survivors. If we don't ask about these symptoms, our patients won't tell us about these symptoms. And again, another symptom, another syndrome that will impact a woman's quality of life. Several large cohort studies have demonstrated an increased risk of death from any cause when women undergo a premenopausal oophorectomy, particularly before the age of 45, and if they don't use estrogen therapy. Parker performed a Markov decision analysis to estimate the optimal way to manage women who are just at average risk for ovarian cancer. They considered all mortality from coronary heart disease, hip fracture, stroke, ovarian cancer, and breast cancer. The highest rates of survival were seen in the women who had ovarian conservation, either when they used estrogen therapy or without estrogen therapy, and they measured survival to 80 years. The Women's Health Initiative study is the only cohort study to contradict these other studies, but we must interpret that Women's Health Initiative study with caution, in that the women who underwent a BSO in these studies, this observational study, the average age was 63 years old in this population, and the level of hormone use was quite high. 80% of those women were using hormonal therapy. So in summary, the vast majority of the literature supports that oophorectomy performed in premenopausal women has a deleterious effect on overall mortality. So let's talk about cancer risk. Again, ovarian cancer is very, very scary. I think all of us will agree with that. Our oncologists in the room will certainly affirm that. It's estimated that 1,000 ovarian cancer cases could be prevented annually if we removed ovaries in every woman over the age of 40 at the time of a benign hysterectomy. Though this long-term benefit from performing oophorectomy is predicated on the assumption that all of these women will use hormone therapy and will be compliant with that therapy. And we know that that's just not the case. As many as 30% of women will discontinue their hormone therapy within 1 year after their oophorectomy. Oophorectomy prior to menopause will reduce the risk of breast cancer deaths, and this may often affect many women's decisions to request oophorectomy to reduce their cancer risk. Though there are other studies, such as the Nurses' Health Study, which show a significant increase in overall cancer deaths with oophorectomy. And so that also needs to be added to this conversation that we have with women who are specifically seeking oophorectomy to reduce their cancer risk. The data on lung cancer and colorectal cancer are mixed. So when it comes to coronary heart disease, the Nurses' Health Study also had a lot to offer. There was an increased risk of coronary heart disease at all ages, and this risk persisted for 24 years. This risk was greater in women who were younger than the age of 45 at the time of their oophorectomy, and the greatest risk was seen in those women who were younger than 50, and again, those women who did not use hormone therapy. Now, these findings are also supported by the Mayo Clinic study and the Swedish Healthcare Registry study. The Women's Health Initiative study, again, contradicts this increased rate of coronary heart disease, but again, this was an older population of women and they were using hormone therapy. So what about the neurologic system? Premenopausal oophorectomy is associated with an increased rate of cognitive impairment and a steeper slope of decline. There's an increased risk of early onset dementia before the age of 50, as well as an increased burden of Alzheimer's disease and neurologic death. Though these associations do not hold up when oophorectomy is performed after the age of 50. The interesting thing is that when we add hormone therapy to these women, and these younger women are depicted in blue and purple, a little bit hard to see, if we add hormone therapy, the slope of decline will decrease, but that hormone therapy needs to be initiated within 5 years of oophorectomy and continued for 10 years. When you discontinue the hormone therapy, this benefit decreases. Sexual dysfunction. 80% of untreated premenopausally oophorectomized women will report one or more sexual problems, including dyspareunia, diminished sexual desire, and response. In the Maryland Women's Health Study, BSO was associated with anorgasmia within 1 year of oophorectomy, and those odds of anorgasmia increased by 7% for each additional year of age. Oophorectomy is associated with hypoactive sexual desire disorder, and this is thought to be in part from removing the residual androgens that are produced by the menopausal ovary. So the effects of oophorectomy on sexual function are not just dependent on hormone or the removal of hormones, but it's also a complex interaction of how abruptly we lose the hormones, the proximity to menopause, and whether or not you use hormone therapy. Hormone therapy, of course, can mitigate some of the physical signs of the genitourinary syndrome of menopause, as I showed earlier, but that does not necessarily help with those hypoactive sexual desire components such as orgasm and satisfaction. Estrogen deficiency is associated with a loss of bone mass, particularly when it occurs early in life. There's been shown to be a decreased bone mineral density at the spine, the hip, and the femoral neck when you compare this with naturally menopausal women whose ovaries were not removed. 6 years after oophorectomy, women are twice as likely to have the rate of bone loss compared to naturally menopausal women. And estrogen therapy, starting it within 3 years of surgical menopause, can restore preoperative bone mineral density levels. But starting estrogen after 6 years of surgical menopause will stop the bone loss, but there will be no restoration of preoperative bone mineral density. So again, we see that hormone therapy can mitigate the risk associated with oophorectomy when it comes to bone loss, but the effects are limited to duration of use. So we'll move on to future surgery. And this is often cited as one of the reasons why, if we're in the territory of the uterus and in the pelvis, why not go ahead and take those ovaries out? A recent study presented long-term follow-up looking at the cumulative incidence of future surgery in women who underwent a hysterectomy, but their ovaries were left in place, and they compared that to a reference group of women who had all of their pelvic organs intact. The bottom line here is, in 30 years of follow-up, yes, there is an increased risk of surgery, future surgery for oophorectomy. But if you look here, the delta is only 2%, and I'm not sure that that 2% difference is enough of a justification for us to just go ahead and take ovaries out every time we're doing pelvic surgery or doing a hysterectomy. So, in summary, there are benefits associated with premenopausal oophorectomy. We can reduce our risk of breast cancer, ovarian cancer, and we can minimally reduce the risk of future surgery. However, there is an abundance of risk, as shown here. Vasomotor symptoms, genitourinary syndrome, symptoms, sexual dysfunction, cognitive impairment, bone loss, and cardiovascular disease, as well as all-cause mortality and cancer death. So I want to shift gears a little bit and share with you what we do locally. How are we doing? This is not meant to call anybody out, but I think if we know better, we can try to do better. So our own Lauren Verrilli and a couple of medical students did a retrospective chart review just this past year. And we looked at charts over a couple-year period of time. And what we found were a full 1/3 of our patients here received no counseling about their menopausal symptoms and treatment options. Factors that were associated positively with counseling included a younger age at oophorectomy, as well as BRCA positive status. Factors that were negatively associated were perimenopausal age range, prior surgery, and if the surgical indication was a concern for malignancy. 80% of these patients experienced symptoms, and those women who received preoperative counseling were more likely to use alternative therapies. So I think our own data suggests that we have some room to improve, and I'm encouraged that we can. So much of what we've talked about is how hormone therapy can mitigate the risk here, and when we see hormone therapy can be beneficial on all of these risks associated with oophorectomy, with the exception of some components of sexual dysfunction. So let's talk a little bit about hormone therapy and why we are a little bit reluctant to prescribe it in our own patients. I think most of the fear and reluctance stems from the Women's Health Initiative. And so I don't want to rehash all of that, but I think you can't have a conversation about menopause and hormone therapy without talking a little bit about the Women's Health Initiative. So the Women's Health Initiative was a randomized placebo-controlled trial to assess a question. Does hormone therapy prevent chronic disease, specifically heart disease and cancer? There were about 28,000 women in this study, and as I said earlier, it was an older population. The average age was 63. There were two arms, a conjugated equine estrogen arm combined with medroxyprogesterone acetate, and then a conjugated equine estrogen only arm. These results were released on a hot summer day in July, and it was without any sort of involvement from the principal investigators in the study. So it was the acting director of the NIH released these data to the media. The media reported the absolute risk and not the relative risk, and this caught like wildfire. I think we might describe that as fake news today, maybe that's what we call that. And fake news is really hard to overcome. So all of these years later, we are still dealing with the fallout. And what the data showed was there was an increased risk of breast cancer, coronary heart disease, and strokes. And so they stopped the conjugated equine estrogen progesterone trial. The estrogen-only trial continued for a few more years, and then that was stopped after there was a noted increased risk of stroke. So I said earlier, at the time, 80% of women were using hormone therapy. And in the women who were undergoing oophorectomy around this time, 90% of them got hormone therapy following their surgeries. That number precipitously dropped. So today, post-WHI, only 10% of women who are undergoing oophorectomy are using hormone therapy. And this has had a dramatic effect. It's estimated that there were 50,000 premature deaths between 2002, when these studies were released, and 2011. The problem here is that WHI population was much older, and we should not be extrapolating that data to a younger, premenopausally oophorectomized group of women. So hopefully we will catch up with the data now that we have almost 20 years of data, new trials, new therapies, and that we will do a better job of offering hormone therapy to our patients. And please know that we're not unique in Wisconsin. This is a national problem, and Lauren's data, I'm sure, is generalizable to many institutions around the country. So when our patients come in, they're still concerned, even though we know that this risk of breast cancer is really small. It's understandable. Breast cancer, we get a lot of attention. We give a lot of attention to that. But I think it's helpful when we're talking to our patients to put the cancer risk into context. So when we look at conjugated equine estrogen combined with medroxyprogesterone acetate or conjugated equine estrogen alone, we can compare those risks, the risk of breast cancer, to that of being a flight attendant, having a high BMI, having your first child at an older age, and having increased bone density and increased breast density. All of those factors elevate your risk of breast cancer much more significantly than using hormone therapy. And actually in the Women's Health Initiative, conjugated equine estrogen alone was associated with a reduction in breast cancer. So what about our BRCA mutation carriers like Amy? Breast cancer risk is of particular importance to these women, and we do a lot of risk-reducing BSOs for these women. Estrogen therapy, several studies show that estrogen therapy does not necessarily increase these women's risk of breast cancer, so it is safe in most circumstances to use hormone therapy for these women. So just next month, everybody will be running around thinking and wearing red dresses, promoting heart disease awareness in women. And as gynecologists, we have an opportunity to help address the prevalence of cardiovascular disease. It is the leading cause of death in women. And the risk of cardiovascular disease can certainly be modified by the surgical procedures we perform and whether or not we prescribe hormone therapy. This next slide shows the many benefits of using estrogen therapy and its role and its effect in the cardiovascular system. So I think it's important to share with our patients that there are benefits to their cardiovascular system, that hormone therapy initiated earlier in the menopausal time period is cardioprotective. So I just wanted to share with you the latest position statement from the North American Menopause Society about hormone therapy, and this specific text is about premature menopause. Hormone therapy is approved, and this is reviewing all of the latest data that we have. Hormone therapy is approved for women with hypogonadism, premature ovarian insufficiency, or premature surgical menopause when there are no contraindications, and that there are health benefits for menopausal symptoms, the prevention of bone loss, cognition, mood issues, and in observational studies, heart disease. So unless there is a contraindication, estrogen therapy is indicated for these women who've had a bilateral oophorectomy and are hypoestrogenic to reduce their risk of vulvovaginal atrophy, dyspareunia, and osteoporosis, and as well as there's benefit on atherosclerosis and cardiovascular disease, as well as cognitive decline and dementia. So what are the contraindications to hormone therapy? Unexplained vaginal bleeding, severe active liver disease, estrogen-sensitive breast or endometrial cancer, active coronary heart disease, stroke, dementia, having a personal history of VTE, porphyria or hypertriglyceridemia. But these risks and these contraindications are fairly rare in our patient population. So what are we talking about when we talk about hormone therapy to mitigate those risks associated with premature oophorectomy? Estrogen is the most effective treatment available for vasomotor symptoms, and of course, as I shared earlier, certainly can be cardioprotective, neuroprotective, protects the bones. We should consider we should add a progestogen if our patients who have been oophorectomized continue to have their uterus in place. And we can consider using estrogen for an extended period of time if the uterus has been removed, as was the case in the Women's Health Initiative study. It was the progesterone arm that had the increased risk of breast cancer. So there is some consideration for using estrogen for an extended period of time when a hysterectomy has been performed. It is always important, because hormone therapy isn't without its risk, that we are periodically reevaluating the risk, the benefits, and if there are other alternatives that can be used as women continue to age or their risk profile changes. Estrogen can be delivered in a variety of preparations. There are oral preparations, vaginal preparations, and transdermal. I do want to highlight transdermal estrogen because the benefits are seemingly are outweighing those of oral estrogen when we look at observational studies. Transdermal estrogen does not depend on GI absorption, and because it avoids that first pass of the liver, we can get reduced variation in the circulating levels of these hormones, which improves the estradiol-estrone ratio. And as you may recall from physiology, it's estradiol that is the more potent estrogen. And because the transdermal estrogens do not increase the level of coagulants, we see a reduced incidence of VTE and stroke. It does not elevate sex hormone binding globulin, so we have more free testosterone levels, so that gives it a better profile for our patients who may experience sexual dysfunction. And it doesn't promote inflammatory markers, again, leading us to a benefit in the coronary heart disease. There are other newer treatment options. Bazedoxifene combined with conjugated equine estrogen is known as Duave on the market, is a tissue-selective estrogen receptor complex that was approved by the FDA in 2013 for the treatment of vasomotor symptoms. Because of its selective estrogen receptor modulating properties, it is stimulatory to the bone and can be used for the prevention of osteoporosis while providing endometrial protection. So for those patients who have a uterus in place that are not so keen on using a progesterone, this is an ideal drug. It has not been associated with stimulation of the breast or endometrial tissue. Not everyone is a candidate for estrogen therapy, and so there are other alternatives. Now, many of these alternatives will do nothing to mitigate some of those other risks that are associated with premenopausal oophorectomy, but they can be helpful in addressing some of the vasomotor symptoms, and I've included them. It's important for us to know the levels of evidence around these therapies to avoid inadequate treatment or inappropriate use of some alternative therapies. When it comes to the treatment of the vulvovaginal symptoms, estrogen, again, is going to be the most effective therapy to stop the progression of some of those chronic changes that result from estrogen deficiency. Estrogen will lower the vaginal pH. It will improve that capillary growth to the vaginal tissue, which will lead to vaginal thickening, increases the vaginal moisture, and alleviate many of those genitourinary syndrome of menopause symptoms. And we see improvement in about 6 to 8 weeks of therapy. Newer therapies capitalize on the conversion of DHEA to estradiol and estrone in the intracellular space. This can restore vaginal tissue, and it will act on those deeper levels of the vaginal tissue that estrogen does not get to. So this is a newer drug. Unlike some of the estrogens where you can plateau off to a twice weekly maintenance phase, this DHEA is prescribed on a daily basis with no plateau phase. In addition to using a hormonal therapy, so whether that's estrogen or DHEA converted to estrogen, I think it's important that we talk to our patients about the symptoms in the vulvovaginal space that will result from estrogen deficiency. Again, many of these women will not bring it up, so if you don't ask, they're not going to tell you about them. So, and then they're reluctant because they may feel like they're the only woman dealing with these issues. So it's important to educate our patients about these symptoms, normalize them, provide them some anticipatory guidance that these symptoms will develop. Using a multidisciplinary approach is effective. So sex therapists, pelvic floor physical therapists are often helpful, as well as using lubricants and moisturizers, whether or not the patient is sexually active, and vaginal dilators can be helpful to maintain patency of the introitus as well as the vaginal caliber. Estrogen therapy mitigates the bone loss, and in addition, we should be counseling our patients about other preventative things and behavioral lifestyle changes that they can do to augment bone preservation, and that is eating a well-balanced diet that's high in calcium and includes vitamin D, exercise, so weight bearing and muscle strength training, and looking at our patients' risk factors and other health lifestyle behaviors such as excessive alcohol or smoking, which can lead to declines in bone mineral density. So how long do we continue therapy? So we should have no tolerance, right, for not prescribing therapy. And we want to continue this, the minimum speed limit. This says 50. I would say at least 51. So the average age of natural menopause in this country is about 51.5 years. So we would want to continue hormone therapy in our patients who undergo oophorectomy at least until the age of 50. After the Women's Health Initiative, we were telling patients you want to stop at age 65. We would use the lowest dose for the shortest amount of time period. But where we are now is we have to individualize treatment, so periodically assessing if your patients are still symptomatic. I know it feels uncomfortable to continue hormone therapy to the age of 75, but what we do know is that there are many women who continue to be symptomatic, and to arbitrarily stop at a certain age could cause harm to those women. So have a conversation with your patients to figure out if treatment is still necessary. So let's go back to Amy. We prescribed, what would you do for Amy? No one? Are we going to treat Amy? What do you? Okay, transdermal estrogen. Physiologic doses. Those answers are both correct. So we treated Amy with a transdermal form of estrogen. She applies an estradiol patch weekly. She came back to us a year later and she was doing well. Her vasomotor symptoms had resolved. Her vaginal symptoms were markedly improved, and her overall well-being was much better. We will continue Amy on this dose. She's got at least a few more years, and we will continue to reassess her risks and the benefits of treatment. So in conclusion, we need to keep in mind most women are only at average risk of ovarian and breast cancer, and it may not be necessary to remove their ovaries. There are plentiful risks associated with a bilateral oophorectomy performed before the age of 50. Very few women are at high risk for ovarian cancer and breast cancer. And for those women, I think we do a really good job of performing risk-reducing surgery, and we actually, as we see, we do a pretty good job of counseling those women about therapies. Hormone therapy does not increase the risk of breast cancer in our BRCA patients after risk-reducing surgery. And if you are going to perform a oophorectomy before the age of 50, I implore you to consider hormone therapy to decrease the other health risk associated with that surgical procedure. Timing is everything, so if you're going to remove the ovaries and you're going to start hormone therapy, do that sooner than later so that we can mitigate all of those risks. And as Anna said, you want to consider physiologic doses, not just a standard naturally postmenopausal, older postmenopausal dose. These women will need higher levels of estradiol replacement. And let's stop extrapolating that Women's Health Initiative data not only to these premature surgically menopausal women, but even our other naturally menopausal women who don't necessarily share the risk. And it is important to individualize these discussions about oophorectomy and hormone therapy using a shared decision-making model where you are sharing the best evidence that you have available, but also inviting patients to share what their concerns are, what their values are, and coming together to form a decision that will work best for them and a decision with which they can be compliant. And we recognize that many of these discussions can be quite challenging. I know in a busy office setting, we have a lot to go through. And we're always happy at our menopause clinic to have those in-depth conversations and provide consultation for these patients who are a bit more challenging. Thank you so much.
Okay, Kate, up here. You're good.
Awesome. Questions?
Thanks, Makeba. That was a great overview. One of the questions, and the Parker-Markov model, I feel like set us back a little bit over the years. And every time I get bored, every single answer is, I would never take anybody's ovaries out until age 65. A lot of Parker's newer data actually says that isn't necessary. You have 50 is the magic number. So how would you answer that question for the patient who's 58, postmenopausal, and has to have a hysterectomy? How would you have that discussion about her ovaries? And is there a new number we should be thinking about?
I really appreciate your comment, Steve. It is tricky, and I think that is where shared decision-making really comes in, because every woman is completely different, and what she values may be different. I have been noticing in many of our patients who are well beyond the natural age of menopause, so average age of menopause, which is 51, after they undergo an oophorectomy, postmenopausal, they haven't had a lot of vasomotor symptoms, they will come back and might have some of these symptoms. The ovary isn't producing estradiol in large amounts, but we are still producing some androgens, which could be very important for bone health. And while the data about neuroprotection show that earlier ages of menopause, surgical menopause, are associated with cognitive decline, there could be a small risk that those changes could be accelerated if we are removing ovaries. So there is no easy answer. I don't think we have the sort of magic number, but there has to be an individualized conversation about some of these less well-studied effects that might occur in these older menopausal women.
But it is true that 65 is not a magic number, correct?
No, 65 isn't a magic number, no.
How do we get that?
False, news.
Fake news.
So I'm feeling a little bit like I've removed a lot of postmenopausal ovaries that perhaps I maybe shouldn't have removed. And I'm wondering sort of if you could just go through what your counseling is for the 63-year-old lady who's having a hysterectomy, say for prolapse, and asks about her ovaries. What would you tell her? And if she says, what would you do, or what would you tell your mom to do? What would your counseling be?
Well, I can't remember which resident was with us in clinic last week. We had a 65-year-old who came in, and actually her mother was recently diagnosed with an ovarian cancer. And this woman was visibly shaking in the room. She was very, very anxious, and she wanted her ovaries removed. And the conversation that I had with her was much like the conversation that we've had this morning. She's not at an increased risk for ovarian cancer. Your ovaries may still be providing you with some benefit. So, and the risk of having a surgery in the future is quite small. So if it were my mother, I would likely tell her to retain her ovaries. And you've probably done a better job. You don't be too hard on yourself, because if you've been doing prolapse surgery, you probably haven't taken out as many ovaries as some of the rest of us.
So I was wondering if you could explain a little bit how to do the hormone holiday, so how to assess. So if you have someone who had a BSO at 40 and she's been on hormone physiologic treatment until 51, now she's 51, what's the best way to go about doing the hormone holiday, and to figure out what dose to put them back on afterward, or when you can graduate them from hormone therapy?
So what I typically will do, I will have my patients stop their hormone therapy about a month prior to an appointment with me, and then have them chart their symptoms to see how symptomatic they are. So there's really no way to know without having this small window without that hormone exposure. And again, it comes back down to some of us may be able to tolerate a hot flash here or there. There are some women who are so fearful that maybe they're doing a presentation or they work in a very stressful environment or not stressful environment, and they live in constant fear that when that hot flash will occur and how that might impact their daily living. So that sort of level of impact and bother is unique for each patient. So that, again, I can't overemphasize enough, that is where you have to have this conversation with how bothered are you by your symptoms and how willing are you to tolerate the risk associated with hormone therapy. I think what we can say for most patients, those risks are relatively small. So it's undergoing a holiday, having them chart their symptoms, and then having a conversation about any residual symptoms that they may have in light of all of the data that we have about the risk and the benefits of hormone therapy. Dr. Erin.
Thank you. That was a great presentation, and we are so lucky to have somebody keeping track of such an important but complicated area. So I remember 2002 very well. I was an internist in the OB department, and everybody had a really different read, I think, of the Women's Health Initiative study. But I think what became really clear in the ensuing years is that sometimes cold turkey stopping hormones was not the right strategy to wean people. And I'm just wondering at this point, is there a standard approach to weaning that people should be considering when people do decide it's time to stop?
No, there isn't a standard approach. I would agree cold turkey, in my observations, doesn't really work well, and so sometimes we will have patients maybe who are on the patch who are cutting their patches in half to lower their dose, or they will apply their patch less frequently to gradually accommodate to those symptoms. You know, we certainly know when we go from having an ovary that's producing estrogen and we cut them off, when we literally cut that ovary, you know, that is a dramatic, causes a dramatic effect. Not only on those vasomotor symptoms, but also on our vaginal symptoms and on the bone. That change is not so abrupt, though, when we have been padding that and cushioning patients who are undergoing that a natural menopause. So there is no agreed upon method of weaning.
I think we have time for one last question. Not a competition, but thank you for a great talk. That was really interesting. I have a question, a scenario, because I've seen this a few times, where someone in menopause, either surgical or spontaneous natural menopause, and who's also a breast cancer survivor or history of DCIS, has primarily like vulvovaginal dyspareunia symptoms. How would you counsel them on those treatment options in addition to lubricants, vaginal dilation, sex counseling, things like that? I guess I wonder, is vaginal estrogen preparations safe for them, or is this like kind of a more individualized conversation if they're willing to take the risks?
So to answer the latter question, generally they are safe. When I am engaging in those discussions with patients, I will wrap around with their oncologist. We have to appreciate that patients have a whole range of information that is being given to them and how they've interpreted that, and their concern with the future cancer is a real thing for them. And so I do my best to make sure that we're all on the same page. When we give vaginal estrogen, while you can detect it in the serum, it is at levels that are much lower than a naturally menopausal woman. So I think we can give it with a lot of safety and reassurance, though, that there are many patients who don't need to use it, or maybe they're on aromatase inhibitors and other things where we want to keep those estrogen levels really, really low, and those aren't good candidates. I am hopeful that maybe there will be some other therapies coming down the pike, specifically for our breast cancer survivors who are living for longer periods of time and that are certainly affected by these symptoms. And of course, reminding them of those other adjunctive therapies, lubricants, and daily moisturizer use that can help with those symptoms. Unfortunately, the vaginal preparations get the same sort of labeling by the FDA as our systemic preparations, and that stops a lot of use of what could be a very beneficial therapy in a local area. Stops many patients from using that, and they would certainly are missing out on the benefit of local vaginal estrogen.